Good morning again, dear colleagues. Today's meeting will focus on the treatment of various types of vertical strabismus. Due to certain circumstances, Professor Igor Aznavran is not able to speak for you today, so I will do it instead of him. In our clinic, Professor Igor is the one who is specialized on the vertical strabismus surgery, especially in cases of superior oblique palsy and complicated syndromal cases. It's a great honor for me to tell about our approaches and techniques of operating different types of vertical strabismus. First of all, we need to recall the anatomical structure of the extraocular muscles. Normally, the eyes occupy a primary symmetrical position of gaze due to the special balance of these muscles. The secondary position of gaze is the eye movement from the primary position directly to the left or right, as well as straight up or down. And the third position of gaze is the eye movement that involves both elevation or depression and a turn to the side. The transition of gaze from the primary position to the secondary position doesn't lead to any rotation of the eyeball meridians. However, in the third gaze position, the eyeball deviates vertically with a turn of the gaze to the side and rotates on its axis. Thus, the medial rectus muscle turns the eyeball inward, aided action, while the lateral rectus turns it outward, aided action. These two muscles are antagonists. The nature of their action remains constant in any the eye's initial position. When the other four muscles contract, the final direction of movement primarily depends on the initial position of the eye, meaning the position of the eye at the moment the movement begins. The action of the superior rectus muscle consists of turning the eye upward and bringing it inward, along with rotation. When the inferior rectus muscle contracts, it causes the eye to move downward and rotate outward. This is the action of these muscles if the eyeball was in the primary position of gaze at the start of their contraction. Let me remind you about the action of the superior oblique muscle. Only the tendon from its pulley to the attachment at the back of the eye behind the equator plays a role. In this case, the muscle mainly acts as a rotator, moving the upper limbs inward. Additionally, the eyeball is slightly lowered and deviates outward. The inferior oblique muscle also attached to the sclera behind the equator. It has the same orientation of the muscular plane and axis of rotation as the superior oblique. When the inferior oblique muscle contracts, it results in rotation outward with the eyeball turning upward. This type of movement concerning the oblique muscles applies only to the primary position of gaze. Vertical strabismus can be categorized as concomitant, dissociated, or paralytic. It may result from previous neurological diseases, injuries, or congenital syndromes. It may be isolated vertical strabismus, which is exclusively linked to the involvement of vertical muscle, as well as it may be combined form with other types of ocular motility disorders, such as convergent or divergent strabismus, nystagmus, and so on. Understanding the type of strabismus is important primarily for planning treatment strategies. Therefore, in the context of this presentation, we will present several clinical cases for clarity. Let's start with diagnostics. It's possible to measure the exact angle of strabismus using a synaptophore, but we encounter a number of problems. The first one is a limited scale for measuring vertical strabismus, 10 degrees. The second problem is difficulty in clarifying the nature of the refixation movement in combined forms of strabismus, where multiple extraocular muscles are involved in the pathological process simultaneously. In such situations, our favorite video oculograph helps us conduct an accurate diagnosis of strabismus type. We have previously discussed this device multiple times. This video oculograph allows us to study eye movements in natural conditions. The assessment of deviation occurs automatically in all directions of gaze. It's possible to accurately evaluate the angle of strabismus even with low vision and any distance. Particularly important for patients with vertical strabismus is that we can also measure cyclodeviations. To provide more clarity, let's move directly to the analysis of clinical cases. Concomitant vertical strabismus is a condition in which one eye deviates upward while the other eye, when the fixing eye is switched, deviates downward. Here we can see a report of the examination conducted using the video oculograph. As we can see that when fixation is made with the left eye, the right eye shows a deviation of 7 degrees upward. And on this slide, you can see the reports for the same patient, which shows that when the left eye is covered, it deviates downward by 9 degrees. It's important to assess the degree of deviation not only in the primary position of gaze, but also during aided action. In this case, we see that there is no increase in hypertropia, indicating that the involvement primarily pertains to the vertical rectus muscle. For this patient, the preferred surgical procedure was a unilateral weakening operation on the vertical rectus muscle. After completing all necessary calculations with the mathematical modeling program, a recession was performed on the superior rectus muscle. To assess the muscle, we don't use cutting instruments. In our practice, we use radio wave knife, which allows us to cut the tissue without hitting the electrode, manual physical pressure, and simultaneous coagulation. The incision is performed in such a way that the muscle tissue remains intact. This helps to minimize the development of adhesion in the future. For suturing, we use 7.0 Vicryl. Suturing is performed using a special right hook with groove, which helps to avoid damage to the sclera. Next, we measure the distance from the limb to the equator. Then we mark the point of recession in accordance with the previously performed calculations. I would like to emphasize once again that performing a deep recession behind the equator is crucial to achieve the desired result and provide a torsion effect. For detaching the muscle, we also use our radio wave knife and a hook with a special protector to prevent damage to surrounding tissue. A good result was achieved after just one surgery. As you can see on this report, when the right eye is covered, there is no any deviation upward. Meanwhile, the left eye doesn't move downward in response to provoking anymore. This is how our patient looks like after undergoing surgery for vertical strabismus. As for dissociated vertical strabismus, these conditions require increased attention as they are often associated with various syndromes. Perhaps the most common among them are the syndrome of superior oblique muscle dysfunction and Brown syndrome. These are fundamentally different conditions, varying in their causes, clinical presentations, and treatment strategies. In the case of superior oblique muscle underaction, we can observe a relatively straight alignment of the eyes in the primary gaze position with a slight upward deviation of the left eye. However, during lateral gaze, there is significant deviation with the eye on the affected side being retracted upward. When looking straight ahead, we also observe vertical deviation that increases with provocation using the cover test. But how we can determine which specific vertical muscle is involved and to what extent? To answer this question, we use our video oculography. An important advantage of the video oculography is that it captures eye deviations in all gaze positions and generates a steady report where all deviations can be assessed in degrees. In this case, we see that with both eyes open and looking straight ahead, the horizontal angle of strabismus is 4 degrees, and the upward deviation of the left eye is 7 degrees. We perform a cover test on the right eye and instruct the patient to fixate with the left eye. We observe that there is no vertical deviation, only a slight horizontal angle of 8 degrees. However, when we cover the left eye, we immediately observe an upward deviation of 17 degrees. Then we perform cover tests and determine the difference between the amount of vertical deviation in primary gaze position and in maximal aided action. As you can see on the graph, when the left eye closed and looking straight ahead, the left eye deviates upward to 28 prism dioptries, which corresponds to 16 degrees. When we ask the patient to look toward the affected side to the right, we observe that the hypertropia in aided action increases to 46 prism dioptries, meaning there is an increasing of the vertical deviation by 11 degrees. For this patient, the preferred surgical procedure was a unilateral strengthening operation on the superior oblique muscle. After conducting all necessary calculations using the mathematical modeling program, a fold of the superior oblique muscles tendon was performed. Dear colleague, as you can see on the video, to assess the muscle, we also use a radio wave knife, which allows us to cut the tissues without any manual physical pressure. So we also use Vicryl 70 as a suture material. Also use right hook with a groove, which helps us avoid damage the sclera and surrounding tissues. When suturing the muscle, the needle is inserted and withdrawn in the maximum avascular area. Professor Aznaurian performed surgery for weakness of the superior oblique muscle. After the surgery, when the patient looks straight ahead and during the cover test, a slight vertical angle remains for the left eye, but during aided action, there is no longer an increase in hypertropia. There are deviations within 1 degree. To eliminate the residual vertical strabismus, a second surgical step was performed, a deep recession of superior rectus muscle on the left eye. After the second step of surgery, orthotropia was achieved. Now let's analyze a clinical case with Brown syndrome. Brown syndrome is characterized by a condition in which the patient is unable to elevate the eye. And when attempting to look to the side, the eye is lowered. This syndrome most often develops due to the anatomical anomaly in the superior oblique muscle. To confirm that the patient indeed has Brown syndrome and to conduct differential diagnostics with other ocular motility disorders, we recommend performing MRI examination of the orbit according to the International Ophthalmological Protocol developed by the doctor of our association. In this case, the MRI revealed some thickening of the superior oblique muscle of the affected eye. A final decision was made regarding the planned surgical treatment strategy. In this case, we performed a surgery aimed at lengthening the tendon of the superior oblique muscle. In this photo, you can see the results we achieved after the surgery. As a result of normalizing the function of the superior oblique muscle, the patient was able to adduct the affected eye toward the nose without any restrictions in its movement. As you can see, dear colleagues, vertical strabismus represents quite complex cases, often accompanied by combined pathologies of the ocular motility system. Each case is unique and requires a special approach during diagnosis, while planning surgical treatment and when prescribing vision therapy in the postoperative period. Today, through the examples of several different cases, I aim to illustrate this complexity nature of vertical strabismus. Dear colleagues, thank you very much for your attention. Thank you very much for your time. And I would like to remind you once again that in November, Professor Igor Aznaurian will see patients at our clinic, Crystal Vision in Bahrain. And you can take advantage of this opportunity if you have any patients with vertical strabismus whose diagnosis need any clarification. So you can use this possibility. And now I look forward to your questions.